And we are back with one of our most famous sessions that we have, this audience has come to enjoy, and we are very excited for our Ask the Pediatrician session. This will be our last session of the day. So thank you everyone for hanging with us. We are very excited to be able to welcome Dr. Dubinsky with us today, who is one of our presenters who is a clinical assistant professor of pediatrics with Georgetown University School of Medicine, and also did her training here at VCU, some of her training here at VCU, and then is participating on the American Academy of Pediatrics Virginia Chapter Return to School Workforce Committee. And then we have Dr. Sriraman, who is an associate professor of pediatrics at EVMS and the Division of General Pediatrics for Children's Hospital of the King's Daughter. And she is also with the American Academy of Pediatrics Virginia Chapter and is a part of the executive board. Thank you. I'm going to go ahead and turn the screen over to you ladies.
Very good. Good afternoon, everyone, and welcome. I'm Diane Dubinsky, and I wanted to just take a minute to thank all those that created this seminar for the opportunity to participate, especially to Tracy White and Joanna Pitts, who has worked with us on the Virginia chapter, and we've enjoyed that camaraderie. My cohort, Dr. Sriraman, she'll introduce herself.
Hi, everyone. My name is Dr. Natasha Sriraman, and I just want to thank Carol and the whole group for organizing this, and to thank all the participants for all of their thoughtful questions, and just for taking the time to, help all of our kids and really kind of make it a partnership between the schools and the pediatricians. So thank you for doing that.
So the format for this afternoon's Ask the Pediatrician, we have taken your questions that you've sent in to us, and we have tried to answer them in a fairly concise format. Some of the questions, I will give you a heads up, were very broad and in and of themselves could take an entire hour to answer. So we're just trying to highlight what we think was the important parts of it that you might want to hear. And if there's time at the end, you could type into the Q&A and we'll see if we can answer any other questions if time allows. And let's see if these will advance. There we go. So I'm going to start out with the first question, and it was that you would like more information on POTS and dysautonomia. And of course, this is one of those major topics that we could lecture on for hours on end. But POTS is referred to as postural orthostatic tachycardia syndrome. It's a condition that affects the circulation, and there are three forms of it. There's the neuropathic form with peripheral denervation. There's the hyperadrenergic form, which is overactivity of the sympathetic nervous system, and the hypovolemic form, which is from reduced blood volume. Symptoms most affect women, young women in the ages of 30 to 50. And common symptoms are lightheadedness, dizziness, fainting or near fainting, abdominal pain and bloating. There can be headaches, insomnia, diarrhea, and constipation. Rapid heart rate, especially when standing from a reclining position, and symptoms that are specifically relieved when you sit back down or lie back down. And symptoms can come and go over a period of years. The etiology or the cause of this is very variable. There's post-viral causes, pregnancy causes, post-head trauma, and then just autoimmune conditions that can be associated with it. And many times the cause is never identified. The diagnosis, the gold standard is what's called the tilt table test, where you strap a patient onto a table and you basically stand them up from a lying position and look for changes in their vital signs, their EKG. There can also be times where we'll also look at laboratory analysis and echocardiograms as well. Treatment is usually to prevention with increased fluid and salt intake, and teaching the patients to rise and let themselves come to equilibrium and give themselves time. There are medications for more severe cases. And we, interestingly enough, have found that good exercise routines can help mitigate the symptoms of this. Dysautonomia. So POTS is one of the forms of dysautonomia. Dysautonomia is a more broad category of other conditions. And again, there's the neurocardiogenic, the POTS that we just described. And then there's a genetic inherited familial dysautonomia syndrome that can be associated with decreased tears, inability to regulate body temperature, and that is more common in Ashkenazic Jewish heritage. And then multi-symptom atrophy, which is rare in children, so I'm not going to go into it, but it can occur in older women. And again, these can affect multiple symptoms, multiple systems, and can occur independently or in association with other conditions. I did want to point out that the Dysautonomia Foundation has the dysautonomiainternational.org. It's a great resource, and you can go there if you want more information. The next question was, could you provide any hacks with getting children to cooperate during procedures? So each child, as you know, is different, and the approach to each child has to be age appropriate and individualized. Educating a child on procedures ahead of time does help. Based on the age, a toddler, you might want to just basically explain to them what's going to happen that day. They don't really process tomorrow or the next day or a week from now. Preschoolers might process a little bit more. You could start to educate them a day or so in advance. And older children, especially adolescents, may want to have time to think about it, to talk about it, the procedure that's coming up, and what it entails. It's important to reassure all children that someone will be there. If it's not yourself, someone will be there to help them. Never lie about what's going to happen. Don't tell them it's not going to hurt if it is going to hurt. But try to explain to them that maybe the pain may be quick or brief, and after a few minutes it will go away, or whatever is unique to that procedure. Recognize fear and crying as normal, and don't ever tell a child, oh, you know, I want you to be brave, don't cry. It's okay if that's how they need to express themselves. Bring items of comfort with the child, or allow them to have a favorite blanket, a teddy bear, something age appropriate, a book if they're older. Distraction techniques are really great, having them listen to music, singing songs if they can, depending on what the procedure is, or reading a book. And then kind of after the procedure, recognizing how they felt and letting the child express their feelings or concerns. What is the most important thing that we can do to promote health in the school-age child? And I'm going to turn this over to Dr. Natasha.
Yeah, thank you so much. This is a great question, but again, a broad question. So the first thing I want to discuss about promoting health in school-age children, and I think children across all ages, is obviously advocating for healthy food options. And this is going to look different in school districts. It's going to look different in different states and kind of the kids in your school. So I write breakfast and lunch, you know, depending on your population of the school. A lot of kids who qualify for free lunches will also be there for breakfast. So taking that into account when I talk about it within my pediatric office, I do ask them how many meals they're eating at school versus at home. Just to give you some background, over 1/3 of the children in the US are overweight or obese. This is a huge change from just 10 to 15 years ago, where being overweight or obese was actually the exception, not the rule. The National School Lunch Program, which provides for a lot of our kids, served over 5 billion lunches per year. And that probably number is obviously growing. And the last estimate was about over 30 million children were served lunches through this program every day. And just to highlight back in 2010 when then President Obama signed the Healthy Hunger Free Kids Act. Next slide, please. If you click it again. So I just want to, I don't know if other people have read this article. There was an article about 2 years ago which showed what school lunches look like in different countries. So the first example is from Brazil, and you can kind of see the salad, the veggie options, the beans. I believe those are plantains or something similar. In Finland, you can see like the small crepes, fruits, a lot of the sweet potatoes. Greece, you have baklava, yogurt, lean chicken and rice, along with a lot of fruits and vegetables. Next slide. Italy, fruits, pasta, baguette, again, salad and greens. South Korea, a lot of the fish and vegetables and things like that, and kimchi. And this is a general school lunch of mashed potatoes, peas. You can see the fruit in kind of a juice, like in their juices, cookies and chicken nuggets and ketchup. Next slide, please. So I think to highlight, our food options are probably not the healthiest in the country, and trying to advocate for whatever changes can happen so kids are getting more nutritious choices, especially for those kids who may be eating even 2 meals at school. I think that's something important to remember, because a lot of the even the breakfast options are pretty fatty, and a lot of times there's a lot of sugar, which can obviously impact them later in the day. Another thing that we can promote health, my kids are a little bit older now, middle school and high school, but I remember when my children were in elementary school, is really advocating for recess and time outdoors. And I was seeing this as a mom and as a pediatrician when my children were elementary school. Many times recess was taken away as a method of punishment. And I never understood that, because I would notice that when my daughter, who's now in college, if some of the class was misbehaving at lunch, the entire class would lose recess. And already they had been sitting for 3 hours up into that point, and then the time they're supposed to have for recess after lunch was taken away. So that's really counterproductive. A lot of times there's less time for recess because teachers are working hard to meet all this criteria, that we have SOLs and standardized testing, which yes, I do understand the importance of, but again, it's kind of, we're making more time for this and taking away something that's probably going to help them academically. And this is counterproductive. I used to have this discussion with principals and moms in my school, is that recess, as we know, and being outside and just having free playtime, it promotes physical health, social development, and it actually leads to better cognitive performance. And creative play is so important. And I really want to highlight the importance of free play, because yes, they may go outside for phys ed and PE, which is of course important, but just to highlight the importance of just to have free play, because a lot of the kids now, what we see is after school, they may have activities, but again, it's kind of in a constrained system, whether it's, travel, baseball, or dance, or gymnastics. Our kids are really not having this just time to have this creative and free play. And on the next slide, what you see, this is a great policy statement, which I have used personally in my kids' schools when they're elementary school, to kind of show the evidence to whether it's the principal or whoever, to show that what is the role of recess in school and actually how that helps academic performance and cognitive performance. So I think that's a great role for teachers and school nurses to play, instead of taking away recess or limiting it. It's actually better to kind of keep it in place, and also even try to increase it, and just giving kids those opportunities to be outside.
Great. So the next question was, how safe are some of the air purifying systems being used in classrooms for students with asthma? And that's a direct typing of the way the question was worded. I think it was more, how safe are they for students with asthma, not that the air purifiers are for students with asthma. So I wanted to go into that because a lot of schools are looking at air quality, especially during COVID, and speak to the different types of air purifiers that are out there. So one of the more common ones are ozone generating air cleaners. These are used sometimes in large commercial buildings, and they create ozone to clean the air through chemical interactions. There are issues with ozone and ozone exposure, which I'll come back to in a minute. Then there's electronic air cleaners. These charge particles in the air and cause them to stick to surfaces, and so therefore takes the particles out of the air and puts them on the walls and the floors and in filters as well. Many of those electronic air cleaners, you have to be careful and look at them closely, can also create ozone as a byproduct. And then you have filtering air cleaners. These remove particles by passing the air through a filter such as a HEPA or MERV rated filter. And these are by far the safest and the most effective filtration systems that are out there. So for safety, ozone, as you know, is 3 atoms of oxygen. And inhalation of ozone at certain levels can cause coughing, chest pain, throat irritation, shortness of breath, and can aggravate asthma. So knowing what type of air purifying system you have and how much ozone is being produced and is in the air is important. OSHA does limit the exposure to no more than 1/10 of a part per million for over the course of 8 hours. And NIOSH limits the exposure to no more than 1/10, but they don't say for how much time. And then the EPA has maximum outdoor average concentrations of ozone of 0.8 parts per million. So that gives you some guidelines to use. And just to note that filtering air cleaners are the safest and can actually help reduce symptoms of asthma and respiratory symptoms due to air pollution and contamination. So looking for those HEPA and MERV filters are the most important, and staying away from ozone generating room purifiers. The next question was on physical evidence of child abuse. What physical evidence of current and past child abuse, what should we look for? And this is, again, one of those major topics that could be a whole conference in and of itself. However, children's reactions to exposure to violence can be immediate or can appear much later. And I think that's really critical to know, that it doesn't have to be what happened yesterday or over the weekend at home. It could be what happened months or years ago. Reactions differ in severity and present with a variety of behaviors, and they vary based on age. Besides the obvious signs of physical trauma, of bruising, bleeding, and unexplained, I should say, injuries, there are different behaviors that you'll see. And I've listed basically under age 5, irritability and fussiness, easily startling, thumb sucking, bedwetting, fear of the dark. These are and new things. Obviously, a child who's been thumb sucking their entire life and is still sucking their thumb at 5, that's a different scenario than a child that never sucked their thumb and is now starting to do it. So we're looking for changes in behavior, frequent tantrums, clinging to caregivers, and changes in level of activity. As you get older into the mid-childhood ages, difficulty paying attention, unusual quietness, being upset or withdrawn, being unusually tearful or sad, that's unexplained by other reasons, decreased school performance, decreased appetite that's not explained in any other way, and getting into trouble and not following rules. And then for your tweens and teens, aggressive behaviors, a lot of sassing, talking back with greater frequency than what's normal for tweens and teens, using drugs and alcohol, engaging in risky behaviors, sleep disturbances with excessive fatigue, and with being withdrawn or just wanting to be alone. So those are some of the things to look for in children as a red flag for possible abuse. This question was, how can school nurses help students and parents with detachment issues after returning to in-person learning? Again, each child can have very different experiences during this pandemic. It's not a one-size-fits-all. Each child may have experiences related to parental job loss, food insecurity, family depression, alcohol or drug use in the family, abuse or illnesses and death in the families. And other children will show much, much higher levels of resilience and coping skills based on the support that they've had within their family. I think it's important to prepare ahead and start talking to children about returning to school and preparing them. For younger children, frequent discussions ahead of returning, and maybe even taking them on a drive-by and reminding them what the school looked like and where they'll be going to school again might help. Discussing fun memories that they had. Do you remember when you were in school last year and you did this or you did that type story, which will make them remember those fun times, and discuss differences that they're going to encounter. You know, when you go back to school, it's going to look a little bit different than it did last year, and the desks will be farther apart. Everybody's going to be wearing their masks. And lunch may not be in the lunchroom. It may be in your room. You may be outdoors more, things like that. Acknowledge what has happened. Acknowledge that life is different now, and not so much to just say, you know, suck it up and deal with it, kid. You don't want to do that. You want to just let them talk about what's different. And allow them time to talk. The younger children, once they get back into school, having more extended circle times and check in as a class. How's everybody doing? Is it fun to be back in school? It's a lot different with our masks on. Older children and adolescents will want more peer support and maybe having peer groups to talk through things. And then having the school nurse or the school counselor available for, quote, office hours, where they can come in and talk one-on-one. Creating activities that allow and encourage students to build connections regarding these issues will help. And then referring for professional intervention when significant concerns. So if you find that you've got a student that you're really concerned about that doesn't seem to be adapting after a few days back in school, then you might want to consider speaking to them, to the family and to their pediatrician or physician about referral. What are your recommendations for parents who have children with symptoms of autism or other related diagnoses, including ADHD? Are you aware of specialists in the Northern Virginia area? So I took this question as being a referral type concern of not knowing where or how to refer parents of or families of children with special needs of autism and ADHD. My first referral is refer back to their primary care doctor. Their primary care doctor is often aware of what's available in that local community and the referral patterns for that community. So if they do have a primary care doctor, that would be the first place to go. If they don't have a primary care doctor, trying to arrange for them to get a primary care doctor would be a great help from the school health aides and school nurses to try to get them set up with a primary care physician. AutismSpeaks.org is a huge resource, and I point you to that website. You can filter by state, by age, and severity of symptoms, and it will give you all kinds of resources for advocacy, autism-friendly services in that community, employment and post-secondary education, evaluation and diagnosis resources, health and medical and dental resources. Finding a dentist that can deal with a child with autism is important. Housing and community living resources, safety, school resources, support groups. It just goes on. A huge resource. So I point you to that website to help you with what's available in that community.
So the next question was asking why physicians fail to complete the hearing, vision, and developmental screening on physicals. So just to give you some background, we do a screening question at every visit, actually starting at the newborn visit. Do you have any hearing or vision concerns? We assess for development starting, as soon as they come to us from the hospital. We look for, gross motor. Is the baby following, all the way up through? We hand them over to our adult colleagues. But objective screening, where we're doing a hearing and the vision test, and just these are kind of just the basic screening tools. We do a photo screen. You do the Snellen, which is the chart. It can be either pictures or the letters. And then the hearing, where, you know, they hear the beeping in their ears. So those are objective screening methods, and those are required. And you can see kind of the ages. Vision starts a little bit early, 3, 4, 6, 8, 10, up through 20, and hearing is around kind of the same time. So I just want to highlight, I think there's a misconception that we do an objective screening at every single yearly physical, which does not happen. If we have a concern, and in this case, if they're 7 and they're not going to have an objective screening, if I have a concern, then I'll go ahead and order it. But the general kind of screening, what's going to be done by the nurse even before they're seen by the physician, doesn't happen at every yearly visit. You also have to understand that at younger ages, the child has to be cooperative. We have to consider the developmental status of every child. So every 4 and 5-year-old is not created equal. Sometimes we have 4-year-olds who can be very cooperative, and then I still have 7 and 8-year-olds who get distracted and, you know, don't hear any of the buzzing, you know, the beeping in their ear and things like that, and get distracted. So again, just to really assess that 3, 4, 5 age group is every child is a little bit different. Starting at 9 months, we do something called an ASQ, Ages and Stages Questionnaire, but kind of in the toddler age range where they may be starting preschool, we actually start doing, we do developmental surveillance at every visit, where we ask generalized questions based on their age group. And again, depending on level of prematurity and what age they are, we do counteract, you know, that they may be X amount of weeks or X amount of months behind, whereas a 6-month-old may be different than a 6-month-old who was born, you know, 5 or 6 weeks early. But developmental surveillance is done at every visit so that we can intervene. My philosophy is the sooner the better. But autism screening, we start at 18 months. We do it at 18 and 24. And that is, we use something called the modified checklist for autism in toddlers. In our clinic, if there is one missing, like if they missed the 18-month visit or the 24-month visit, or one of those were abnormal, we also go ahead and do it at the 30-month visit, which is 2.5 years of age. So sometimes some kids will have 3 of these autism screenings, but they definitely have to have 2. And for our older children, starting in middle school, we actually start screening for depression at their 11-year-old visit. Next slide, please. So how do you address vaccine refusal? So obviously, this audience knows that vaccines do not cause autism. There's been multiple papers about that, and a lot of evidence is there. I encourage, if you haven't already, Paul Offit, O-F-F-I-T, from Children's Hospital of Philadelphia, has some really great resources, and his books are amazing. So I encourage you guys to look him up. So if we have a parent, I think 2 different settings. If you have a parent where you're noticing that they're refusing vaccines, again, referring them back to their pediatrician, because this is basically kind of what we do mostly every day. So having them talk to their pediatrician, because again, we don't know where they're getting the information from. And then when they come to our offices, what we ask, I say mom, but sometimes it can be dad or foster parent or grandparent or the parent. The first thing we do is, you know, what are their concerns? Why are they worried about the vaccines? And then we try to ask them to be specific. We still hear about MMR causing autism, but I think I'm seeing that less. I don't know if Dr. Dubinsky is seeing that less. Sometimes I'll hear about formaldehyde and mercury and kind of those kind of things. Sometimes we hear, well, if I get the flu vaccine, they're going to get the flu. So really just kind of honing in on what their concerns are about, because that's going to help me hone my advice and how I'm going to tailor my talk with them. I ask them where they are getting their information. A lot of times it's, well, my friend said this or my grandma said this. Actually, someone in my practice, a parent told me when they saw that I had my COVID vaccine, I had my COVID vaccine pin. A parent asked me, she had actually told me, like, is it true that you can get paralyzed because I saw a video that someone couldn't walk after COVID vaccine? So I knew right away that wasn't true, because the COVID vaccine wasn't available to the general public, you know, just a month ago. And I always tell my families I went to school a lot longer than Dr. Google, so for them to trust me, and I give them resources that are actual evidence-based and valid resources. And then I also asked them, has there been a previous reaction that they're worried about? Because again, there may be components to the combination vaccines that, if they did have an adverse reaction, a common one is the pertussis, which is a combination vaccine. Then if there is that risk, we can give them a vaccine where that part is removed from it, but that doesn't mean that they're going to miss the other coverage that they get from that vaccine. So really kind of just, again, making it a conversation, really kind of finding out where they are. Are they at the point where they're not going to budge at all? Or are they like, I want to talk about it, or yes, I'm ready, but I don't want to have, all the vaccines all at once. It's going to overwhelm their immune system. So it really, let us do that, because every practice is different. Every pediatrician is different. Every pediatric office is different. Some pediatric offices will be like, well, if you're not going to vaccinate, they will discharge them. I'm in an academic setting. We have a little bit more leeway with our families because we don't want to lose the family, and we want to keep the kids safe and things like that. So really having that discussion, like, we're gonna talk about this over the year. We're going to see where you're at. And then, you have to follow kind of the guidelines of the health system as well, because there are some health systems will be like, if you don't vaccinate, you can't, you can no longer be a patient. So it just goes step by step, addressing each concern. We discuss the risk of illness, and yes, we discuss the risk of death, of contracting certain diseases. I can't speak for Dr. Dubinsky, but I was a resident and I saw measles, polio, pneumococcal meningitis, and measles keratitis here in the United States, not just in India. So I saw a lot of these diseases here in the United States, where I trained up in New York, and we saw kids die or significant illness. So I do mention the significant morbidity and the risk of mortality. And the guideline is that if they do refuse, even if they don't want to do all of them that one day, or we kind of work out a system, but if they do refuse, it is required that they sign. The AAP has something called a vaccine refusal form. So again, just them acknowledging that they've been made aware of the risks and things like that. And at least in our practice, they have to sign it every single time that they come in. So if they refused 2 months ago and they're coming back again, we have to have it signed and in the chart. And I think it's both for documentation as well as kind of protection, so that the AAP requires that as part of the documentation process. Next slide, please.
I just wanted to add that I think that a real important part of what we do, like she said, was that we discuss illness and possible death. The more a community is immunized, as you heard earlier, the more we get herd immunity, the fewer of these diseases we see. And when people don't see the diseases, they lose their memory and don't remember why it was bad to begin with. And I think that's really important role for us, is to remind them of the things that these diseases can cause, so that they understand why it's important to immunize to prevent them. If they've not had a personal experience, then they often don't think that it's going to affect them. And so they feel then that it's not necessary to prevent, because it's not going to happen to me. It doesn't happen here in the United States. I've never seen a case of this. So why are we immunizing millions and millions of children when we don't even see cases of this anymore? And so that's a really important point that we have to make to the families.
Yeah, I definitely see a racial differentiation. I'm the only one in my practice who speaks Spanish, and I'll be honest, there's not one immigrant family who has declined a vaccine ever in my 20 years of practice, because they're coming from a place where healthcare wasn't as good, and they've probably seen some of these diseases. So I definitely see the difference based on culture and race and things like that.
So the next question was current guidelines for treatment of conjunctivitis and school exclusion. The most common cause of conjunctivitis is viral, but occasionally it can be bacterial, and often it's difficult to determine clinically the difference of what the infectious agent is. And without doing a culture, sometimes you can't tell. Now, it's traditional that we say if there's purulent drainage from the eye, it's more likely to be bacterial. And if there's non-purulent drainage, and just tearing, it's more likely to be viral. It's not always 100% that way. And the only way to know for sure would be to do a culture. However, the time it takes to get cultures back, really, if we waited for cultures on every child with conjunctivitis, we would have a lot of missed days from school. And we try to avoid that and keep kids in school as much as possible. It is most common under age 5 because they don't wash their hands as well, and they touch their face a lot more with their hands. Incubation period is typically 24 to 72 hours. So the Virginia School Health Guidelines call for excluding a child from school with symptoms until they've been 24 hours on antibiotic treatment or without symptoms. Some doctors will opt to wait until the child if a child has not had purulent drainage, to give them a couple of days and see if they get better on their own and not start antibiotics. Others have resolved to prescribe antibiotic drops because the schools often will not let the child back in school without them. So as a result, we do end up over-treating conjunctivitis very, very commonly. But I don't think that we've identified a really good way of determining which ones are viral and which are bacterial. And just because it's viral doesn't mean it's not contagious. Both viral and bacterial are contagious and can be spread quite easily. So if they're viral and they're getting antibiotics and they're coming back to school the next day, they still could be spreading viral conjunctivitis if it's viral. So that's an important thing to know. Just because they've been treated doesn't mean they're not going to be not contagious. Different jurisdictions handle this differently in various ways. And this is I've been in practice over 40 years, and the same question's been asked for 40 years. So I don't know that we have a really good answer. I was hoping in my career I would see rapid diagnostic testing to be able to determine the difference. And we might get there, but we're not quite there yet on conjunctivitis. How do you see HIPAA applying when you or your staff communicate with school nurses? So this is a great question because I hear this all the time. I hear this within the medical community, just even between providers and hospitals and emergency rooms and doctors' offices, is that, we're going to fax you a release form before we give you the results of the lab work that was done in the ER last night. And by law, that's not necessary. When you're sharing the care of a patient and you're sharing medical protected health information, if it's there is a need to know in order to provide care for that patient, you can share that information without a release. And that does include school nurses as well. And I put the site, the HHS site that addresses this at the bottom of the slide. I'm not going to read to you the whole HIPAA privacy rule here, but it basically says that it can include school nurses on that. Now, I will tell you that if it's a particularly common type of topic, for instance, let's say we have a child who's asthmatic and they're going to be receiving medications during the school day, and there needs to be clarification, the school nurse can certainly reach out to the doctor's office and ask for clarification on that dosing schedule if it's not clear on the forms that have come in. And we can give you that dosing schedule and tell you what medicines without needing a clearance. So if it's something that's simple like that. You get into more muddy waters when you're dealing with some mental health issues and sharing of information. And it probably is wise to get releases from the family, from the parents, the guardians of these children before you start sharing a lot of detailed mental health history with each other. So I'll just leave it at that. How should we screen children for vision and hearing under age 3? So this is a continuation of Natasha's previous comments, and I just want to mention that the screening that she talked about that we do in the office under age 3 is part of the medical exam. We look for fixation, following, red reflex, pupillary response. ptosis, drooping of the eyelids, and that sort of thing. Instrument-based screening, which she mentioned, the photo screening, can be done as low as age 6 months quite effectively, and has really helped in identifying children with vision issues. This is not something that's being done in the schools at this point. So it's really, if you feel a child, if you're in, I guess, in the preschool venue and you see a child that you think might be squinting a lot or holding a book particularly close to their face, just refer them back to their pediatrician. The screening can be done in the office. Hearing screening under age 3 has to be also an instrument-based type of screening. We use otoacoustic emissions where you put a probe in the ear and you can measure their hearing response if needed. Routine screening is done at birth and then repeated again by 2 years of age if there's high risk in the family, and repeated multiple times if they don't pass their screening at birth. So most of the kids, by the time they get to school, should be identified with significant vision or hearing issues. And I think the next slide just shows, if you can't read this, but this is the preventive pediatric health care that's put out by the Academy of Pediatrics. And on the left column are all the things we screen for, and the different color categories are the different ages. Green is infancy, yellow early childhood, red mid-childhood, and blue adolescence. And then the dot is every time we do it. So that shows you the different screenings that we do at different ages. You can just look this up by Bright. If you Google Bright Futures, it will come up, periodic screening Bright Futures.
Yeah, and I think the order is a little goofed up. So that was this. So when I was talking about, if you go back one slide, Diane, where the dots are where we do it, whereas the stars are recommended. So again, highlighting that hearing, objective hearing and vision screen, they aren't done at every well child check. And then next slide, I think they got mixed the order, but basically this is kind of the physical form for the state of Virginia. So again, highlighting what we as pediatricians are filling in or should be filling in. And so the top part is vitals and things like that, the nurses will fill in, but kind of the developmental screen. Sometimes pediatricians will just mark a line through within normal. Sometimes I just write normal. And then where the hearing and vision screen are supposed to be added along with the dental screen. So again, if there's not an objective screen done, like if it's the off ages, hearing and vision screen will not be highlighted, will be filled in. And that last part, the summary of findings, will mark well child, but will always mark conditions that need everything. And if you go down, some of it got cut off, but allergy, if there's any medications that are needed, especially for asthmatics, but again, for asthmatics or kids who need EpiPen or things like that, a separate med in school form will come to you, or the asthma action plan will come to you. So there's going to be, for those students who have additional medication, there's going to be added paperwork. And especially for our kids, if there's any risk of food allergy and anaphylaxis, that's a whole different set of instructions and things like that. So really just sometimes if it's not filled in, usually this last part where I have other concerns highlighted, they'll talk about, a child needs an evaluation for speech and or things like that. So again, just taking a look at that bottom box.
The next slide is also out of order, so I'll have you mentioned this.
Yeah, so this was with the autism vaccine refusal. So again, there's no association. There was this is just one study, but they're talking about a meta-analysis which looks at multiple studies, and this one looked at 10 studies showing that the MMR does not cause autism. Yeah, this is out of order. Okay, so the question was, when the recommended intervals for Hep B shot are not met, is it recommended that child repeat the 4th shot to meet state requirements? So this is just the highlighted, a little easier to read version of the CDC chart showing when Hep B, what the intervals look like. Generally speaking, the first Hep B is given at birth, depending on where the baby delivers or if it's a home birth, parental preference. I would say probably 97% of kids usually get their first Hep B in the nursery before they leave, but sometimes they will wait till they come to see the pediatrician the first time. And then the subsequent intervals, and you can see that next slide, please, Diane. So the intervals have to be, there has to be at least 4 weeks between dose 1 and 2, and this is actually counting weeks, not from like February 15th to March 15th or something like that. It has to be actual 4 weeks between doses 1 and 2. So again, just to highlight the fact that if a parent doesn't want the child newborn to get it in the nursery or wants to wait a little bit, having that, and now we use the VIS system, which is the immune registry state system. So it has to be 4 weeks between dose 1 and 2. There has to be 8 weeks between dose 2 and 3. And from the first dose to the third dose, there has to be a full 16 weeks. So sometimes that second dose is given a little bit early, or that third dose is given without that interval of 8 weeks. So again, calculating the number of weeks between the different intervals and from start to finish. So if a child has not met those requirements or one was given earlier than expected, we recommend do not restarting the series. So if you find that, obviously, and most of the times we hope to catch that before we send that to the pediatrician, back to the school. But of course, if the school nurse finds that it was overlooked and things like that, just send them back to the pediatrician, and we do not restart the series. We just go ahead and technically give them a 4th shot that meets the requirement. There are some rare exceptions where we would restart the series. Some children with liver disease and some other reasons may have titers drawn. And if they show that they have not built up an antibody response to Hep B, we will have to restart the series, but that's in rare cases. And again, giving that 4th dose is required if that 16-week interval is not met. And again, you can go to cdc.gov. That's what we use. We look at schedules there. There's the general vaccine schedule as well as schedules for kids who may have fallen behind. A lot of times for children who maybe get their initial vaccine series from different countries. So just, if there's a 7 or 8-year-old, we don't start back with the infant vaccine. So there are different kind of schedules to look at if we're playing catch up based on the age of the child.
And this is our final question that was sent to us ahead of time. What is the best way to facilitate communication and collaboration? And this is a fabulous question. I was really happy to see that. It's a major, major issue. And it requires commitment on all parties, school nurses, parents, and the healthcare provider on that. There's multiple modes, as you know, of communication. And yet, oftentimes, the best is still a phone call. Even though telephone tag can be an issue, it's still sometimes the most effective way to communicate is just directly speak to each other. So much gets lost in the interpretation sometimes of what's happening via email. Using email, because if you are passing protected health information, needs to be encrypted emails and HIPAA compliant, and faxing forms and such to the offices can help to get those filled out. Providers often return calls, in the middle of the day during our lunch hour or at the end of the day when we're done seeing patients. And this is in direct conflict with what school nurses are doing. So you're done, you're gone by maybe 4 o'clock in the afternoon, and we're sitting there at 5:30, 6 o'clock at night saying, oh, time to answer our phone calls or our emails. So that creates a lot of issues with communicating between providers and school nurses. However, if you can communicate what's best for you and when you can be available, and the providers can also try to help if they know you're not going to be there after 4 p.m., they'll make an effort to try to call you back before you leave. That would help facilitate those communications. And then lastly, get the parents involved. It's really important, because if we're not communicating with the families, then oftentimes we may have a good idea of what we're doing, and you may have a good idea of what you're doing, and the parents are totally out in left field, not understanding that we've even discussed it or talked to each other, that sort of thing. So getting everybody together on the same page is really critically important. And with that, that ends our pre-listed questions that we received.
And I just wanted to make a point to the last slide, and I think just in general, for those families where English is not their primary language, to really advocate for having a staff member who speaks that language or having an interpreter available, because in addition to a lot of the regular barriers, that language barrier is really a hindrance for a lot of our parents where English is not their primary language. So advocating for that would be huge. Thank you.
And Carol, are you coming back on to? I don't see her. Here she comes.
And just to add on to what Dr. Natasha said, even here, and I'm sure it's very similar at Children's Hospital of the King's Daughter, if there's a language barrier, always recommend to your families to request a translator or someone to assist them, because I know that we are always welcome to having those individuals participate in appointments, whether that's via the phone or depending on the language, can be in person. So always let families know that those resources are available and that we are happy to connect them to those. And I'm looking, at this point, it looks like we are just getting a ton of accolades and appreciation for your time and for bringing this valuable information to them. And I know you guys did a lot of preparation around those questions, so I hate to ask you to dig deeper anymore today. So at this point, thank you ladies so much for your time and greatly appreciated. And then the presentation and the slides will be posted to a private page for registrants to access. And if we do get any additional questions for you, I will email those to you directly.